Let's go ahead and get started. So we're recording now. Okay, so today we're going to be doing a review lecture. So this is going to be a little bit more interactive than some of the other lectures we've had. So I'll be throwing out some unprompted questions. Like, feel free to chime in. I don't like to just stand up here and talk because I get tired of my voice. But we're going to be looking at the pelvis and perineum, which you've already learned about from Dr. Askew. And we're also going to be reviewing the anterior thigh, and anterior medial thigh, which you did that lab, I think, 2 days ago. So should be relatively good review. There's a lot of material, so we're going to be moving somewhat fast-paced through this. But pay attention, we are covering all but 3 of the course pack chapters in this review, so relatively high yield for this hour. All right. So in order to really understand the pelvis and perineum, I think it's really important to get a sense of what the bony structures are. So with that, the bones of the pelvis, right? You have 2 hip bones, you have your sacrum, and you have your coccyx. Now those 2 hip bones developmentally were 3 separate bones, right? They're listed up here. You've got your ilium, ischium, and pubis. So your ilium is going to be this bone right here, coming around. You've got your pubis up here in the front, and going back to your ischium back here, and there's your ischial spine. We'll go into more of the landmarks on the next slide, but the point I want to make here is in the adult, right? Those 3 bones that make up that 1 hip bone, those are all fused together. Anyone remember where they're fused at? I hear acetabulum, right? Acetabulum is right here, right? That's where the head of the femur is going to articulate, right? So talking about those bony landmarks of the pelvis are going to be really important in the sense that there are a lot of origins and insertions, right, from muscles around the pelvis. And you have to know what the landmark is to understand what we're even talking about when we just give you a random origin and insertion. So some of these bony landmarks. Let's look at the ilium first. So right here we have the iliac fossa, right? What muscle is arising from the iliac fossa? Iliacus. Yep, we saw that on the last exam. Right, up here at the front, so we're anterior, we have a superior iliac spine, right? And if we have a superior iliac spine, what do you know? We have a inferior iliac spine, right? Now, if we have anterior, and we specifically call it anterior, that probably means that we also have a what? Posterior. Yep, and we have, if we look over here on the back side, we have a posterior superior iliac spine and a posterior inferior iliac spine as well. Right. So now going up to the pubis, up here in the front, we have our pubic crest coming right across, right? So there it is labeled. And then we have these rami. So we have a superior pubic ramus and we have an inferior pubic ramus, right? So here goes our superior pubic ramus here, inferior pubic ramus here. Right? What is this arch right here? Maybe the pubic arch, right? That sounds good. All right. And then what about these big holes? As it's labeled. Obturator framing. That's going to be important because we're going to have our obturator membrane, our obturator canal. We're going to have different things coming through here, obturator nerve and artery. We'll look at that in just a minute. All right. And then back here on the back, 2 really important structures that are going to be landmarks for us to know in forming different structures. We have our greater sciatic notch and lesser sciatic notch. We'll look at this on the next slide, but in combination with the ligaments of the pelvis, those are going to form the greater sciatic foramen and lesser sciatic foramen. And it's going to be really important to know what structures pass in and out of those foramen. Right? So talking about some of the borders, right? This unit has a little bit more borders than our last unit did, so you're going to need to know those for the different things. Femoral triangle, adductor canal, pelvic inlet, right, are the brim. So the pelvic brim, and the inlet is a space in between, that is going to separate your greater pelvis, which is superior, and your lesser pelvis, which is inferior. Your greater pelvis, that superior part, is your false pelvis. Your true pelvis is that inferior region, all right, that lesser pelvis. All right, so the separation point is that pelvic brim, and I think this image does a really good job of labeling each one of those structures so you can see it following around. The pelvic brim is bordered by the promontory of the sacrum, which is really that superior border of S1, so the body the sacrum. Then you come over here to these ala, or the wings, right? And that's the fused part of the sacrum coming down. You come around to the arcuate line, go up to the pecten pubis. You also might see this as the pectinate line. This is where the pectineus muscle is going to originate. So part of that superior pubic ramus, and going anteriorly to the pubic crest, right? So all of those And then we have our pelvic outlet, which is just the inferior part of the pelvis. So if you go through and you look at a pelvic model, and I say, all right, on the bottom, what is the first structure that I hit all the way around? I would say, well, starting from the front, I'm going to hit my pubic symphysis right here. As I come around, I'm going to hit these ischiopubic rami that are going to go backwards into the ischiotuberosity. And then from there, we're going to take some ligaments that we'll see on the next slide. They're going to go back to the coccyx. So that's going to be the borders of my pelvic outlet. Right, so really important, anytime that we have borders in the course pack, those are all testable, so make sure that you take time to look at those and have those nailed down. All right, so question. Which of the following are not borders of the pelvic brim, which we just saw? So I'm just going to go through these one at a time. You're going to tell me yes or no. So is the arcuate line a part of the pelvic brim? Yes. Iliac fossa? No. Right, iliac fossa up in here. Right, there's an arcuate line down here, so iliac fossa is to superior. What about the promontory of the sacrum? Yep. Inguinal ligament? No. All right. Sacrospinous ligament? You have a sacro-something ligament, not the sacrospinous, but the sacrotuberous ligament. And it's going to be the outlet, but neither one of those are part of the pelvic brim. Right? How about the pubic crest? Yes, right here in the anterior part. The pecten pubis? Sounds good. And the ischiotuberosity? Ischiotuberosity, not a part of the brim, part of the outlet. Yep. So got to be careful when we look at these questions. There are going to be some specifics where you have to recognize, are we talking about the inlet, outlet, those kind of things. Right. Okay. So real briefly, I just want to mention the difference between the male pelvis and the female pelvis. Right. So in the male pelvis, it's a little bit more deep and narrow, which we have right here. So you can see deep and narrow, and female is wide and shallow. And you look at the angles, right? Which one has a greater angle, the female or male pelvis? Female, right? Okay, so going on, talking about some ligaments. I think these ligaments are going to be relatively important because, again, we're going to be forming with these ligaments our greater sciatic foramen and lesser sciatic foramen. And there's going to be some really important structures that pass through those spaces. Right. So the first thing we'll look at is our iliolumbar ligaments right here. So our iliolumbar ligaments are going from our ilium to L5. And what they're doing is they're helping limit rotation around that joint, right? Because you don't want to be rotating too much down in the lower part of your spine. Right. Now we have these anterior sacroiliac, we have posterior sacroiliac ligaments. We also have interosseous sacroiliac ligaments. Those are going to be the main ligaments that are transmitting the weight from the upper body onto the hips. Right. Now this is our friend here, right? Our inguinal ligament. We saw this one a lot on the last exam unit, right? And then this is probably better seen on the posterior view, but here we have our sacrotuberous and sacrospinous ligaments. Now, great thing about ligaments, as y'all have learned up to this point, ligaments tell you where they originate and insert a lot of the time. So sacrospinous, it's originate from the sacrum. Where's it inserting? Or well, where's the other attachment point? Ischiospine. How about sacrotuberous? Ischiotuberosity. Right, so if we look up here, right, there is our ischiotuberosity down at the inferior portion of our pelvis, and right there our sacrotuberous ligament. Our ischiospine, right here, right, we're going to have our sacrospinous ligament. And with those ligaments, like we said, that's going to form our greater and lesser sciatic foramen. So we'll see that on our following slide. That's not a question. But we got a question first. So which of the following passes through the lesser sciatic foramen? All right, so take a minute, and then we'll go through this one. All right, so same thing. We're going to practice going through this one after the other and say, does it go through, does it not? And you can tell me where it does go through if you feel so inclined. So the superior gluteal nerve, does that pass through the lesser sciatic foramen? No, passes through the greater sciatic foramen. All right. Lateral sacral artery? No, doesn't pass through the foramen. Inferior gluteal artery. It says inferior, but no, it's not through the lesser sciatic foramen. Obturator internus tendon. Yes, right. The obturator internus tendon is passing through the lesser sciatic foramen, and then the sciatic nerve, that's passing through my greater sciatic foramen. So this image, I think, does a really great job of showing you the important structures that are passing through each one of the foramen, right? Muscles as well as other structures. Now, you don't really need to know that the region above the piriformis muscle is called the suprapiriform foramen, but know that these are structures that are passing through the greater sciatic foramen above the piriformis muscle. Or these are structures that are passing through the greater sciatic foramen below the piriformis muscle, right? So some of the structures passing above the piriformis muscle, and you might have seen this in lab yesterday, right? Use the piriformis muscle to dictate if you're looking at the superior gluteal artery and nerve, or you're looking at the inferior gluteal artery and nerve. So superiorly, right, great, it's superior. We've got our superior gluteal artery and nerve coming above the piriformis muscle. Then below the piriformis, still within our greater sciatic foramen, we have our inferior gluteal artery and nerve combo, the sciatic nerve, right in close association with that sciatic nerve, we're going to have that posterior femoral cutaneous nerve, which is supplying the back of the thigh. And then we have our pudendal artery and nerves. So the internal pudendal, which is part of your the vessels that you learned about last unit, and we'll see it again here, and the pudendal nerve. Now, I want to take a brief moment to talk about the pathway of the pudendal nerve, because it's kind of unique, and we'll touch on it again in a little bit as well. But the pudendal nerve is going to exit, leaving the pelvis through the greater sciatic foramen below the piriformis muscle. So once it has exited the pelvis, it is then going to wrap around posterior, right, because this is the posterior side, posterior to the sacrospinous ligament, and it's going to enter our lesser sciatic foramen. Right. Once it enters our lesser sciatic foramen, it's in close association with your obturator internus muscle, right, and it's going to be in your obturator canal. And we'll see that on another slide in just a moment, but that is going to now be part of your perineum. So it exits the pelvis through the greater sciatic foramen, wraps posterior to the sacrospinous ligament, and then enters the perineum through the lesser sciatic foramen. Right? And then the other main structure that goes through the lesser sciatic foramen that you need to know is going to be that tendon of the obturator internus muscle. All right, any questions there? All right. So now that we've talked about the bony structures, some of the ligaments, the foramen, let's talk about some of the muscles that are present in the pelvic diaphragm. So the pelvic diaphragm is made up of two large muscles, the levator ani and the coccygeus muscle, but the levator ani has three components, and we're going to name each one of those components. Right? So looking from a superior view, you're going to have two muscles of the levator ani that are originating from the pubis and going to different places. So one of those is originating from the pubis and coming back to the coccyx. So here's anterior, posterior, originating from the pubis, coming back to the coccyx. Anyone want to take a name? Guess the name? It's labeled. Pubococcygeus, right? It says where it starts and it says where it's going. Right? Now, you can't really see it from this superior view, but if I look inferiorly, there's a muscle that runs right below the pubococcygeus, but it doesn't go all the way to the coccyx. It wraps around the back of the rectum. So, let's see. Right here. Right? So, pubis, wrapping around the back of the rectum. We're going to call this muscle the puborectalis. Right? So puborectalis, one of the things it's doing is forming that rectal sling. It's going to help alleviate some of the pressure on that external anal sphincter to help you from defecating without need, right? Keeping the feces in. Right? And then the last part of the levator ani, right here, coming somewhat in association with the ilium, but really coming from the tendinous arch of that obturator internus muscle, going back to the coccyx. That is going to be our iliococcygeus muscle. So the three muscles of the levator ani were the pubococcygeus, the puborectalis, and the iliococcygeus. Right? And then, last but not least, we can't forget the coccygeus muscle as a whole. No other fancy name in front of it, just coccygeus. Right? Coccygeus muscle is this one posteriorly. It's originating from your ischial spine and inserting into your coccyx. Right? And we can see a lot of those same muscles on the inferior view as well. I personally like looking at it from the superior view just because I'm more used to that. The models in lab are really good at identifying these structures, so I would take the time and look through those. Right? Okay, so one of the things that can happen when you have damage to your pelvic diaphragm, right? Your pelvic diaphragm is supporting the pelvic viscera. So if you have damage, maybe during childbirth, you can get prolapse, right? And that's when those pelvic viscera are going to fall through the floor of the pelvic diaphragm. So again, what were the muscles of the pelvic diaphragm? Levator ani and coccygeus, and levator ani, right, has those different components. So if any one of those are damaged, right, and usually there's some that are more specific than others that are more often damaged, pelvic viscera can fall through, right, through the floor of the pelvic diaphragm into your perineum. So be on the lookout for, if you see anything that says like something's falling through the floor, then you're going to be thinking, okay, that probably has something to do with my pelvic diaphragm, and start thinking about the muscles that are associated there. Okay, so now we're going more inferiorly. So we're out of our pelvis and we're looking at our perineum. So our perineum is going to be broken up into really two different regions. You have your anal and urogenital triangles. So again, a lot of borders in this unit, so we're going to need to make sure that we recognize what all the borders are. So we're going to start there. So when we talk about the borders of our anal triangle, we're going to draw an imaginary line between both of our ischial tuberosities. Right, so point here, point there. And then we're going to draw a line backwards to our coccyx. Right back here. Right, and roughly this is going to form the anal triangle. Right. Our urogenital triangle is going to be anteriorly, and we're going to use the same 2 points from the ischial tuberosities, but now we're running up to our pubic symphysis. Okay. Now, recognizing the region that you're in, right? You've noticed this, especially with head and neck, but as we've gone through, if you can recognize the region of the body that you're in, you can immediately eliminate some of the options of structures that you should be looking for. Right. So, for instance, if I know that I'm in the anal triangle, the structures I'm looking for are the anal canal, the external anal sphincter, the ischioanal fossa, which is on the borders, which we'll see in a second, and maybe I'm looking for those inferior rectal branches of the internal pudendal artery, or I'm looking for the pudendal nerve branches that are supplying that region. Okay. Now, the urogenital triangle is really broken up into two different spaces. You've got your superficial perineal pouch and your deep perineal pouch. And we'll go a lot more in depth into both of those in just a moment. All right. So we talked about the anal canal a little bit on your last exam unit, but we're going to bring up some of the important features again. So the upper 2/3 and the lower 2/3 have different vascular, innervation, and lymphatic supplies. Right. So it's important to know, depending on which region you're in, what is the associated lymphatics, neurovascular structures. So the upper 2/3. Right, these are going to be innervated by visceral motor, so your parasympathetic, sympathetic innervation from your hypogastric plexus region, and they are only going to identify stretch, right, because they're not somatic visceral, or sorry, they're not somatic motor and sensory. And then if we go below the pectinate line, y'all remember that? See some head nods, right? We go below the pectinate line, and then we're going to get somatic motor and sensory from the pudendal nerve, and that's going to give us pain, touch, and temperature. And those are those inferior rectal nerves coming off of the pudendal as it's going through the obturator canal. All right, now for the arteries. Right, anyone remember the IMA? Right, from like 2 weeks ago, I know, way in the past. But we have those superior rectal branch coming off the IMA, and that's going to be supplying the upper part of your anal canal. And then, right, if we had a superior rectal branch, we're probably going to have an inferior rectal or anal branch, and that's what's going to be supplying that inferior portion of the anal canal below the pectinate line. Last thing we're going to talk about is lymphatics for this region. Okay, so, I mean, it says it up here, but where do lymphatics for above the pectinate line go? Internal iliac nodes, right? Okay. If we go below the pectinate line, and this is going to be true for most of the peritoneum, superficial peritoneum, we're then going to go to the superficial inguinal lymph nodes. And specifically, we're going to go to the transverse group for the most part. Right, we'll talk a little bit more when we get into the thigh, but the vertical group is draining most of the leg. All right, so any questions here on above or below the pectinate line? All right, so now we're going to talk really briefly about the ischioanal fossa. Y'all didn't have to do this dissection, so that's great. The ischioanal fossa, really the only way that I can think about it is in this coronal section because it's on either side of your rectum. Right. So or your anal canal. And over here, so we're going to talk about the borders. You have your obturator internus muscle. So this is, again, cross-section, so that's what this muscle fiber group here is. And then you have your levator ani coming down as part of your pelvic diaphragm. And then you have your anal canal. And wrapped around the anal canal, you have your sphincters, your internal and external anal sphincters. So this region here is your ischioanal fossa. Now, I don't really think that there's a whole lot, like when I think of the ischioanal fossa, I'm just like fat, because that's what's mostly in here. But the important structures you need to know is right here, you can kind of see this neurovascular bundle, right? That's going to be your pudendal nerve and internal pudendal vasculature, right? So the artery and vein. Right. And here's another view of that if you don't like this really grainy, fatty image. But this is what it actually looks like without. And then right here, you can see that obturator canal, pudendal canal, which is where those pudendal neurovascular bundle is. Right. And then in this region, right here, you see the inferior rectal arteries coming off. Your nerves will be coming in the same region as well. Right. Okay. So we talked about the anal canal, but we haven't quite hit on the urogenital triangle, which has superficial and deep perineal pouches. So kind of getting ready for that, which of the following is found in the deep perineal pouch? Right. So I'll give you 30 seconds and we'll go through this one. All right, so that was a quick 30 seconds. I realized that I got to pick up the pace a little bit. So, is the inferior rectal nerve found in the superficial perineal pouch? No, we just talked about that. It's found in the anal triangle. All right, so that's posteriorly. The mons pubis, is that in the deep pouch? Nope, we'll talk about the mons pubis in just a second as well. Greater vestibular gland. Nope, superficial pouch. Internal urethral sphincter. No, right, that's found up near the bladder itself. Right, the external urethral sphincter is, but not the internal. Bulbourethral glands? Yeah, right, everything else was taken out, so bulbourethral glands has to be the correct answer. Okay, so talking about perineal pouches, this is the best image I could find. Really, there was no good image. So really, we're just going to talk about the borders of each one. So as we're going, so this is inferior, this is superior. This is a coronal cross-section. So it is important when we're talking about superficial and deep perineal pouches. I mentioned this in lab as well. We are saying superficial and deep. We are not saying superior and inferior because the relationship would be flipped. Right? The superficial perineal pouch is the more inferior of the two. Right? That's going to be everything below from Colles fascia up until you get to the perineal membrane, which we'll see in just a minute. But that perineal membrane is the delineation between the superficial and deep perineal pouch. Right. The deep perineal pouch, this image made it seem like it was just this muscle here, but it's not. So I added in these purple lines. Your deep perineal pouch is going to be between your perineal membrane all the way up to that pelvic diaphragm, so anything within that space. What is really important for you to know, other than the generalization of where everything is in terms of depth, is to know what structures you might see in each. So just some of the example structures are listed over here on the side. The superficial perineal pouch, this is where a whole lot of the external genitalia structures are. So in the musculature associated with, so your ischiocavernosus, bulbospongiosus muscles, the glands, the greater vestibular glands and vestibular bulbs for the female. The perineal body is really just a ligament or a fibrous structure that's going to be found kind of posterior to the bulb or the base of the penis. And then you've got your superficial transverse perineal muscles, which to me, they are almost, if we go back to this slide, here's your superficial transverse perineal muscles. They are almost right in line with those that imaginary line between the ischial tuberosities. So in my head, I'm thinking like that's the same thing to me when I'm looking at a cadaver as the posterior border of the urogenital triangle. Right. So, okay, and then deep perineal pouch. Right. This is, again, we mentioned that our internal urethral sphincter isn't part of our deep perineal pouch, but our external is. All right, so this gives us the voluntary control, because it's under voluntary control of urination. Then we have our bulbourethral glands are going to be in that deep perineal pouch. the deep transverse perineal muscles, right? So that's great. The transverse perineal muscle, we have a superficial and a deep one, and they're in the pouch that they say they are. And then also importantly, we have the dorsal neurovasculature of the glans penis and glans clitoris, right, which we'll see maybe on the next slide. Right. So going in, superficial perineal pouch. This is what you can see if you look at the model that is in lab, right, the pelvic model, because it just has superficial structures, because the last thing that you can see is the perineal membrane, which we said was the delineation between the superficial and deep perineal pouches. So that is shown on this image as this fibrous structure here. Right, so that white structure there, that is going to be your perineal membrane. So everything superficial to that is going to be part of your superficial perineal pouch. Right. So, right, we have a female here. We're going to say, and we'll go into the male and female genitalia in just a second, so I'm going to skip that for now. Over here to the side, right, we have our ischiocavernosus muscles. That's going to be the same in males and females. We're coming from that ischium and going over the crus, which is cavernous tissue, so ischiocavernosus. Right, the bulbs, the vestibular bulbs, and the bulb of the penis is spongy tissue. So we're going to call that muscle overlying the bulbs, which are deep in the here. This muscle here is our, anyone guess, in red? Bulbospongiosus, right? Because it's spongy tissue and it's going over the bulbs, bulbospongiosis. Right. Here goes, once again, those superficial transverse perineal muscles. Again, really, I think of these, if I'm looking at this, everything anteriorly, I'm going to call part of my urogenital triangle, and everything posteriorly, I would be in the anal triangle. Right. Okay, and that's everything I wanted to show you there. But let's track the pathway of our pudendal nerve, and I'll also throw in the artery while we're here as well. So the pudendal nerve, we said we're exiting the greater sciatic foramen above or below the piriformis muscle. Below. All right, thank you. So we're going below the piriformis muscle. We're wrapping around posterior to what ligament? Sacrospinous. Right, because sacrospinous ligament is forming that bottom border of our greater sciatic foramen. And we're now entering the lesser sciatic foramen to go into our perineum. So we're not re-entering the pelvis, we're entering the perineum. And we're doing that by going through the pudendal canal, right? That's in association with the obturator internus muscle. And then, so there it goes right here, and it pops out. And we're going to give off some branches here to our external anal sphincter, as well as some of the skin of the anal region. Right, these are going to be my inferior, I've seen anal and rectal nerves, so I don't know which one of those is more accurate. And then as we're coming anteriorly, right, we're going to have a branch right here that's going into the superficial perineal pouch. That's your perineal nerve. Right, and that's going to supply most of the structures of the superficial perineal pouch, the musculature. It's also going to give off a posterior scrotal and labial branch, which is going to do the skin sensation in that region. Now, what you see here, kind of going deep to the perineal membrane, so this fiber here, it's not labeled, or maybe it's labeled on another, oh yeah, it's labeled on this side. That is going into the deep perineal pouch, and that is going to be the nerve, and there's a vessel that runs with it that is going to supply the dorsal part of the clitoris and glans penis. Okay? So, deep dorsal nerve runs deep in that deep perineal pouch, which we saw in that little table, and this is showing us how that happens. Okay? So, any questions here on this slide? Pudendal nerve, pretty important, does most of the perineum. All right, well, if that's the case, then we're going to test you. So, patient presents to the clinic with loss of sensation in the skin of the inferior anal region. It is determined that the nerve supplying the area has been compressed as it enters the perineum by a tendon that's passing through the same space. The compression is being caused by which of the following? So when we get a question like this, we got to figure out what the heck is Ron trying to ask first. So I'm telling you that the skin of the inferior anal region, the sensation has been lost. So what is the nerve that supplies the skin to the inferior anal region? Inferior rectal or anal nerve, right? Yeah, okay. And then I'm saying that the nerve is being compressed by a tendon that passes through the same space. Well, so how does the inferior anal nerve, that's a branch of what nerve? The pudendal nerve. How does the pudendal nerve enter the perineum? Lesser sciatic foramen, right? And the lesser sciatic foramen, what tendon passes through the lesser sciatic foramen? Obturator internus, right? And that's how we work through that answer. Okay. All right. So talking about some of the external structures of the male and female genitalia, you can see these on the cadavers. Right here. So here we've pulled the labia majora and minora apart. Right. So what some of the structures that we want to know going in here, the labia minora as it comes anteriorly is going to have a superior and inferior fold that is going to turn into the frenulum, which is that's the inferior fold. That's going to go into the base of the glans clitoris. And you have the superior fold, which is going to become the prepuce, which is the hood, which is right there and here. Right. Now, our vaginal opening is one of the most posterior things in that vestibule of the vagina. Right. The vestibule, if you remember, is the opening. But anterior to the vestibule, anterior to the vaginal canal opening, we have the opening of the urethra. Right. So this is the urethra opening is anterior to the vaginal opening and posterior to the glans clitoris. Right. So in between the two. Okay, and then over here, right, some of y'all thought I was joking in lab. I actually meant look up a photo of what the clitoral structure looks like. This is not what I would have expected, right? These vestibular bulbs are pretty big, and we saw these on the cadavers, right? They were on either side of the walls of the vaginal canal. And here are our crus going up into our glans clitoris up here at the top. The male structure, pretty much the exact same thing. It's formed up of 3 tubes. You've got the crus coming up, or the crura. Those are cavernosus tissue. There is going to be a bulb of the penis that is made up of spongy tissue, and they're going to run together to form that penile structure that you've seen in lab. And you've seen the urethra passing through. One of those, is it the corpus cavernosus or corpus spongiosum that your urethra is passing through? Spongiosus, all right? And what muscle overlies the bulb of the penis? Bulbospongiosus, right? Because bulb and spongy tissue. Sounds really, really easy to remember that way for me. And then one last thing I want to point out is down here in the superficial perineal pouch. That's where these structures are. You have, in this image, it's labeled as Bartholin glands. Those are also called what are the other name for them? Greater vestibular glands, right? Okay. So, some questions. Which of the following pairs of male and female structures are homologs? So, this is an important thing. You're going to want to know, there's a little table in your course pack, but knowing which structures are paired together is really important. So, is the crus of the penis the homolog of the vestibule of the vagina? No, it would be crus and crus. Right? Bulbourethral glands and periurethral glands. Okay, I see some head shaking, right? But they both say urethral glands. 2 different things, right? The bulbourethral glands are the homolog to greater vestibular. Periurethral glands, prostate. The way I think about this is the periurethral glands wrap around the urethra, right, in the female. When you think about the male cadaver, we saw on our last unit when we looked at the prostate, right, and there is a region of the urethra in the males that is just called the prostatic urethra, as it's passing through the prostate. So wrapping around the urethra. The other thing is the bulbourethral glands. It says bulb. The greater vestibular glands, which are their homologs, are right associated with the bulbs of the vestibular bulbs, right, in the female. Right? How about the scrotum? Is that the homolog to the labia minora? Now, what's the homolog to the labia minora? It's the ventrum skin of the penis, right? So remember when we're talking about the male genitalia, in an anatomical position, that is going to be erect and up, right? So the ventrum surface is going to be like what some might consider the surface, depending on what you're viewing it as, right? So remember the anatomical position when we're going through this. Glans, penis, and the clitoris. Are those homologs? Yep. All right, and then we've got these last 2, which are not correct. Now, I was being a little funny with this one, but Silly Sally always makes fun of little Johnny for being a poor lover. So little Johnny makes a vow to research the female genitalia and the mythical clitoris, and he can finally state, after all of this study, and if y'all don't know who little Johnny is, please look up those jokes. But after the study, Johnny can correctly state which one of these. So take a minute and read through all of these, and then we'll get back with this one. Okay, so I know you might not have time to read through all of that, but when you're getting questions like this on practical or on the exam, it won't be as silly as this. But what you can do when you're answering these questions, and we've done this throughout all of these, is you can answer each answer choice as a true and false question, right? And if you know if something is false or incorrect, then that can't be the possible option. Right, so if we go through this, the artery that supplies the glans clitoris runs through the superficial perineal pouch. Is that true? What artery supplies the glans clitoris? Right, that's going to be that dorsal artery, and that goes through the deep perineal pouch. So A is incorrect. So little Johnny can't say that correctly. The vestibular bulbs are made of the same tissue as the corpus cavernosum of the penis. So this question is asking, are the vestibular bulbs the homologue to the corpus cavernosum? And we answered that in the last slide, they're not. So there's going to be two different kinds of tissues. That's cavernosus tissue versus spongy tissue. The external urethral orifice is located within the opening of the vaginal canal. Is this true? Right, no. And this is a point that gets commonly confused, so that's why it's in here. Right, the opening of the external urethral orifice is located anterior to the vaginal canal, posterior to the clitoris. Right, it doesn't run through the clitoris and it doesn't run through the vaginal canal. Right, the clitoris is located between the inferior and superior folds of the labia minora. True or false? This one's true, right? If we think about what are the superior and inferior folds of the labia minora, right? That inferior fold, that was the frenulum, right? It turns into the frenulum as it goes anteriorly, inserting to the base of the clitoris, right? The superior fold is the prepuce. That's the hood of the clitoris, right? And then finally, the lymph drainage to the lower vaginal canal is to the deep inguinal nodes. So we know that that's not true, but what is the lymphatic drainage to that inferior region of the vaginal canal? Superficial inguinal nodes. All right? Okay, so that takes us out of the pelvis and perineum, which is a lot. Like, it's probably one of the most dense components of this unit. But one of the most important in terms of studying for the exam, in my mind, is the lumbosacral plexus. I would recommend by the time that we finish this unit and you get down through the foot, you go back and you revisit that chapter. Because throughout all the chapters you've been reading up to this point, there's been a little section about the nerve supply and vascular supply for every region. That is all said in the lumbosacral plexus. Right? So I think this is a really great way to review everything you've learned all in one spot. So that said, there's a lot of material here. We're just going to start knocking it out. But the lumbosacral plexus is composed of the ventral rami of spinal segments L1 through S4. Now, in terms of us describing it, because there's a lot of things happening here, I'm going to break it down into three sections: the lumbar plexus, and then I'm going to break the sacral plexus into an anterior and posterior part. Right? So as we're going through this, it's going to be important to keep up with, is something coming off the anterior division of this plexus or is something coming off the posterior division? Right? And what are the spinal segments that it comes off, and what are my innervations? Right? So a lot of material, but again, really good overview for everything that you've learned up to this point. Okay. So I know we're all different kind of learners. So you can look at whichever one of these you want, but this is what the textbook looks like drawing the lumbar plexus. This is my weak attempt to draw the lumbar plexus. This is how I do it. I recommend finding your own way that works for you. And then some people just like tables, so that's down here. So look at whichever one you want while we're talking about this. We're just going to talk through what comes off the lumbar plexus. All right, we're going to start talking about the anterior division. So if you see my drawing up in the top, the anterior division is everything in that yellow color coming off anteriorly. So lumbar plexus, from spinal segments L1 through L4, the lumbosacral trunk, which I do have drawn in this drawing, is not part of the lumbar plexus. Right? So what's not part of the lumbar plexus? Okay, just because I have it up here, I don't want it to confuse anybody, so I want to mention that. So coming off anteriorly from L1, you have the iliohypogastric and the ilioinguinal nerves, and you saw that on your last lab practical. And what I have up here in red, right, you can't barely see, but that's the quadratus lumborum that run across. You saw those actually going across that muscle on your last lab practical because we tested you on that. Then as we go down inferiorly, coming off of the anterior division, spinal segments L1 and L2, we have your genitofemoral nerve. Right, the genitofemoral nerve, as it's going distally, it's going to split into a genital branch and a femoral branch. Right, the genital branch we saw last time when we talked about the cremaster muscle that was in the last unit, but this time it's going to be important with the femoral branch because that femoral branch is going to supply the cutaneous innervation above the femoral triangle. Right, so spinal segments 1 and 2. Then lastly, coming off this anterior branch, you have your obturator nerve. The obturator nerve is going to be really important for that adductor compartment of the thigh. And here it's going to be anterior divisions L2 through L4. Right? And it's going to do pretty much all the muscles of the adductor compartment. Right? Those were all the anterior divisions. We also have some things coming off the posterior division of the lumbar plexus. One of those is the lateral femoral cutaneous. Right? Great thing about this, it says what it does. It's going lateral femoral skin area. Okay? And that's going to be the posterior division L2 and L3. Femoral nerve, right? Femoral nerve we'll see again when we talk about the anterior part of the thigh. But that's going to do the iliacus, psoas major, and pretty much all of the anterior thigh muscles, along with giving off some cutaneous branches. Right? So when we look at the femoral nerve, you're going to see that, and you've seen this in lab already, it branches like crazy right when it's coming into the femoral triangle. Okay? So that is our lumbar plexus. Now we get into our sacral plexus, and there's a lot going on here. For our sacral plexus, as I said, I'm going to divide it into anterior and posterior divisions and talk about it that way, but they are all joined together. When we're coming off the anterior division, right? I always go from top to bottom when I'm talking about this, so you can look at it in the table. But starting from L4 through S1, we have the nerve to the inferior gemellus and quadratus femoris. Now, in my head, I'm like, who named this? Because the spinal segments are L4 through S1, and if I go right down below that, I have superior gemellus and obturator internus. So if you think about the structures in that region, right, the superior gemellus and obturator internus are the two superior muscles, and then the inferior gemellus and quadratus femoris are inferior to that. So you just have to think that the spinal segments are flipped in terms of superior and inferior. The posterior femoral cutaneous, right, you're going to have spinal segments contributing to the posterior femoral cutaneous from both the anterior and the posterior division. Off the top of my head, I think it's the only nerve that has that action. So you're going to get a total S1 through 3, but from the anterior division, you're only getting S2 and 3. Right. Then we have our pudendal nerve. Right. Our pudendal nerve, again, really important for the innervation of our perineum. That's going to be S2, 3, and 4. Right. And that's going to go to the external sphincter, urogenital triangle, and more. Right. All of that perineum area. For a good amount of it is pudendal nerve. And then S3 and 4, levator ani and coccygeus muscle. So if you damage that nerve to the levator ani and coccygeus muscle, that might be another way that you get that pelvic prolapse, right? As opposed to damage, you just damage the nerve. All right. And then your tibial nerve. So I draw tibial, and you'll see the same thing with common fibula. I draw it kind of over here to the side because it's a big one. It's coming from L4 through S3, and it's innervating all the muscles in the posterior part of the leg, for the most part, posterior thigh, except for the short head of the bicep femoris. It's going to hit all of the posterior compartment of the leg, and it's going to hit the plantar aspect of the foot, right? And we'll talk about following that all the way down. It'll bifurcate, but you'll see that in lab this upcoming week. Right, so that is the anterior division of the sacral plexus. A lot of stuff going on there, but if you think categorically, everything is distributed by region. Right? And now for the posterior division. So posterior division, oh look, it has a superior gluteal nerve and inferior gluteal nerve. And what do you know? The spinal segments that are associated are superior and inferior to one another. So you have L4, L5, S1 for superior gluteal, inferior gluteal, L5, S1, S2. So I thought it was good. And then next thing I know, I'm thinking glute max, superior gluteal, yeah. Turns out that's flipped, right? So the superior gluteal is going to innervate the glute med, glute min, and tensor fasciae lata. But the inferior gluteal nerve is innervating the glute max, right? So any of these, right, I have in the table drawing, however you want to study it, but you need to understand if you damage any one of these nerves, what are the associated deficits that I would expect? Right, that's really the aspects that you need to be thinking. And if you want to do this, if I was reviewing this again for the exam, I would go through, as I said, lumbosacral plexus chapter, and whenever I hit a nerve and it said it innervated a muscle, I'd be like, okay, this is the muscle, this is the region, where's the origin and insertion? You can really review everything pretty much in that one chapter if you do it that way. Now we mentioned the posterior femoral cutaneous. Right, we said that gets components from the anterior and posterior division. The posterior division here is giving off S1 and 2. Right, whereas the anterior division gave 2 and 3, for a total of S1 through 3 overall. This is also the posterior division is where we get our nerve to the piriformis. That is going to be S1 and 2, and it innervates the piriformis, like it says. And then lastly, the one that's going down into the thigh and leg is going to be the common fibular. So remember, our sciatic nerve, because I didn't mention this on the last slide, is made up of 2 nerves. It's made up of the common fibular nerve and made up of the tibial nerve. Right, they're both doing different things. And really, when we get into the leg this upcoming week, that's where you're really going to want to follow the different divisions of the common fibular and tibial, because they're going to do different compartments of the leg. Right, both of them are coming off of that sciatic nerve, right? Because it's the 2 together, meaning it's coming from the greater sciatic foramen. All right, so that was a ton of information. I get it, but we're going to try to test it. So, which nerve innervates the sartorius muscle? And then what are the spinal segments that make up this nerve? Right. So, working my way through this question. Well, first I have to know what the sartorius muscle is. Where is it? Right. So, what region of my leg is the sartorius muscle in? Anterior. It's part of that anterior thigh. And we said that there is a nerve that does pretty much all the muscles of the anterior thigh. What nerve was that? Femoral, right? Femoral nerve is going to do the anterior thigh. So, I know it's femoral. Okay, so now I'm down to A and D. All right. Which plexus, lumbar or sacral plexus, did the femoral nerve come off of? Lumbar. So if it's coming off the lumbar plexus, is it going to have any components from the sacral spinal nerves? No, it's going to be down here with the femoral nerve. All right, so we're going to see here L2 through L4. Right? What division of the lumbar plexus did the femoral nerve come off of? The anterior or posterior? Posterior. So again, one of the things you're going to want to think about as you're following these nerves is making sure you know, are they anterior or posterior divisions of each associated plexus? Right? Okay. Now we're done with that. Okay. So now for the fun stuff. We're in the thigh. Let me check the time, make sure I'm going at a decent speed. Okay. We'll go a little quick. The femur. Again, anytime we're talking about muscles, we're talking about origins and insertions. It really does you no good to say, oh, this is the origin and insertion if I have no idea where that's located, right? So we're going to hit this real quick. On the femur, this just giving you an idea, this is the anterior view of the femur. This is the posterior view. On the anterior side of the femur, we have our intertrochanteric line. On the posterior side, we have our intertrochanteric crest. Now, these are in between the trochanters. What trochanters? The greater trochanter, which is superior and laterally, and the lesser trochanter down here. On the posterior side of the femur, how I look at a femur and know that I'm looking at the posterior side is I'm looking for this line right here. Linea aspera, this is going to be the site of origin and insertion for a lot of different muscles. If I move superiorly, I've got my gluteal tuberosity, which is where our what muscle inserts? Glute max, right? It says in the name, glute. And then pectineal line right here, which, believe it or not, that's where your pectineus muscle is going to insert, right? And then another structure important for insertion is your adductor tubercle down here on the medial aspect of your leg, right? Anyone want to guess what muscle might insert there? Part of your adductor magnus, right? Adductor tubercle. Okay. So going into the thigh, before we get to the muscles, and y'all saw this in lab, you have this really thick fascia layer, the deep fascial layer, and it's called the fascia lata of the thigh. one of the things about the fascia lata, and I would be able, think about, so you see cross sections here, right? Know that cross sections are fair game for the thigh and the leg, because what happens with this deep fascia of the thigh, the fascia lata, and the crural fascia of the leg, is they're going to dive into the muscles, or to the bones, and they're going to divide the leg into different compartments. In the thigh, you have an anterior, medial, and posterior compartment. Each one of those compartments has a different vascular supply and has different nerves associated. So that's one of the reasons why you have all of these nerves off the sacral plexus, lumbosacral plexus, innervating specific regions, because there are different compartments within the thigh itself. Right? So be aware that you might get cross sections for the thigh and leg, because there are different compartments there. And then what that means is you need to know the nerves and arteries that are associated, as well as the muscles, so that way if we just put an arrow to something, you can be like, oh yes, that's the anterior compartment, thus it must be the femoral artery, for instance, something like that. Okay, now the muscles of the anterior thigh. We're going to go through these relatively quick because I want to hit the vascular supply. But these are all innervated by what nerve? Femoral nerve, right? And that's L2 through 4, the posterior division. So we have this nice fancy chart over here. But your iliopsoas, right, contributions of the iliacus and psoas major are coming, and they're inserting into the lesser trochanter, and they're going to be the main flexure of the thigh. Right? So when we're talking about the thigh, we need to be careful that anatomically we say thigh versus leg. Right? Thigh is going to be above your knee. Leg is below the knee. Right? Saying medial rotation or flexion of the knee is much different than saying flexion of the thigh. Right? Two different things. So be careful with that when you're reading questions as well, if the question is asking about the thigh or the leg. Right? So the rectus femoris right here, that's part of your quadratus femoris, which is made up of 4 muscles, like quad, and that's going to originate from your anterior inferior iliac spine. Right? All of your quad muscles are really going to be used for extension of the knee, but your rectus femoris is coming from the hip and going down, so it's not originating from the femur itself, therefore it can also aid in flexion of the thigh itself, because it crosses the hip joint. All right. So I'm not going to go through this entire table, right? Y'all can see it, but do be aware of the origins, insertions, and the actions of all of these muscles. All right. Medial thigh muscles. Now this one I'm going to go a little bit into the innervation. So you see in the table that I have green and orange. Well, what's the meaning of that? This is because the adductor compartment of the thigh, the medial compartment, the muscles there are going to be innervated largely by the obturator nerve. But the obturator nerve, if you remember back from the lumbosacral plexus, it bifurcates into an anterior and a posterior division. Anyone know what muscle it bifurcates around? Adductor brevis, right? So it's bifurcating behind the adductor brevis. So the posterior division is going to do the adductor magnus. Specifically, what part of the adductor magnus? Is doing the hamstring portion? Hamstring is going to be, hamstring, like the hamstring, are innervated by the tibial nerve, right? So we're just going to be doing the adductor portion of the adductor magnus and the obturator externus, right? The anterior division, we've got our pectineus, which is most superior. So here goes pectineus there. Then we've got this is our longus, and here it's cut. We've got brevis right here, which is a little bit under longus, and then magnus is deep. And then the most medial of them coming, let's find a good one. Right here, coming down to our pes internus is our gracilis, right? So again, these are the medial compartment of the thigh. Almost all of these muscles are going to be important in adducting the thigh and flexion of the thigh, right? Because they're coming from superior and inserting inferiorly. Okay, so I know this was a really brief overview, but let's do a question. So a traveling circus member has a freak accident, and they sever a branch of the obturator nerve that passes anterior to the adductor brevis. Which of the following muscles will have weakened, specifically weakened, action? So what this question is asking is, you've damaged a nerve that passes anterior to the adductor brevis. So that's our obturator nerve, right? specifically that anterior compartment, that division. So what's not damaged is the nerve that's innervating our adductor magnus or our obturator externus. It's just that anterior division. Weakened. Weakened means that you have not lost complete function. Right? So which one of these muscles would have damaged innervation but not completely lost by losing the anterior division of the obturator nerve? Sartorius, is that innervated by the obturator nerve? No, cut that one out. That's femoral. Adductor magnus, innervated by the posterior division. Right, so that one's out. Adductor brevis, only innervated by the anterior division. So that would be loss of all of the motor function. Right, because there's no other nerve that's innervating that muscle. Pectineus. Right, pectineus is getting dual innervation from the femoral nerve and the anterior division of the obturator nerve. So it would still get some innervation, but it would have weakened action due to the fact that you've lost that anterior division of the obturator. All right, so the answer here is pectineus. Okay. Any questions on that one? Okay. All right. So femoral triangle and adductor canal. Borders. Again, borders are really important. When we're talking about the femoral triangle, you've got your inguinal ligament, you've got your sartorius muscle coming down, and you've got your adductor longus. The floor of the femoral triangle is going to be made up of your pectineus muscle and your iliopsoas. Right. As you're looking at the structures that are going through the femoral triangle, from lateral to medial, right, you have this naval mnemonic, you have the nerve, artery, vein, empty space, lymphatics, or lacunar ligament. Now what I want to point out here, you see the femoral ring. Right, the femoral ring is one of those, and it's up here as well, femoral ring. That is one of those locations where you can get femoral hernias. That's where they're going to come through, that femoral ring. All right. And then over here we have our adductor canal. So our adductor canal is where the femoral artery and vein are going to continue down until they get into the back of the knee. Right, they're going to emerge from the back into the back of the knee by going through the adductor hiatus, which is a fold in the adductor magnus muscle. And the borders here, the medial border, you have your vastus medialis, right? You have your adductor longus, and you have your sartorius coming over the top, because sartorius is coming from lateral to medial. Right? I know I'm flying, we're going to skip that question. Let's see, skip that. Yeah, we're going to hit this real quick, because we're running out of time. The vascular supply of this region. Right, this is coming from the femoral artery, which is a continuation of your external iliac. So external iliac coming down. Right, we're going to have superficial circumflex coming around, inferior epigastric, superficial epigastric, external pudendal. So those are all the branches that might come off before the big split in between femoral and profunda femoral. Now, coming right here, this is this long one in the back. That's our profunda femoris artery. Laterally, we have our lateral circumflex femoral. And you might have seen this in lab. The lateral circumflex femoral gives off an ascending, transverse, and descending branch. Right. The ascending branch, along with the medial circumflex femoral, which is right here, and the inferior gluteal and perforating branches from the profunda are going to form your cruciate anastomoses. Right. So those branches were the ascending part of the lateral circumflex, the medial circumflex, the inferior gluteal, and some perforating branches from the profunda femoris artery are forming that cruciate anastomosis. Okay. All right. Okay. And then lastly, we've got here some the venous structures, right? The veins of the leg. They're draining into, so you have the big one is your great saphenous vein doing that medial part. You've seen this in lab. Right, that's how you identify where the femoral triangle was, because the saphenous vein, great saphenous vein, is inserting into the femoral triangle through what opening? Saphenous opening. Hey, look at that. It's the same name. Yeah.
So the difference between the femoral ring and the saphenous opening?
Yeah. So the saphenous opening is opening into the femoral triangle from above, where the saphenous vein is joining the femoral vein, and then your ring is under the inguinal ligament, where things are entering in from the pelvis, or above the pelvis. All right. And then on the back part of the leg, you'll see this again when you do more of the leg, you have the small saphenous vein, which is going to be draining into on the popliteal vein, which is in the back of your popliteal fossa. Okay, so I know that last part was really rushed, but the recording's getting ready to cut off. So are there any questions about any of this material?